we chose a little bit of a different model yet, and I hope that this potentially can expand a little bit about your thoughts about how this may look not only nationally but within a local context. So to just quickly bring you back to 2009, activity began in April, and we saw a first peak in June in Minnesota, predominantly affecting our pediatric population. To get to some of the previous comments about how you do not need widespread activity affecting the entire population to have surge that will overwhelm certain areas of the healthcare system. And so our pediatric hospitals were overwhelmed and were taking additional measures to triage individuals. We were also hearing about the nurse triage lines that existed within Minnesota being overwhelmed and not being able to meet the need. And so we were concerned about patients with influenza encountering delay in receiving treatment, and also individuals coming to healthcare to receive a prescription for oseltamivir, and encountering people who did not have influenza, and therefore increasing spread within a crowded healthcare facility. We were also concerned about access to medication and those who did not have insurance. As a complete side note, just a few weeks ago we had the death of an individual in Minnesota who had received a prescription for oseltamivir, went to the pharmacy, saw the cost, chose not to, and died within 24 hours. And there were similar instances in 2009. And so as others were talking about, as activity waned within the later part of the summer of 2009, we began seeing cases in early September. And we were very concerned that we were going to be encountering another and even more higher peak of activity. We basically looked around and tried to, as quickly as possible, assess what would be our options for some kind of triage system. And very quickly we realized that in Minnesota we had a very well-developed nurse triage line system. We also looked to see what was the smallest number of partners at the highest level to engage, so we could do this very quickly. And within Minnesota there's a relatively small number of healthcare plans, and the healthcare plans were the ones that administered the nurse triage lines. And so we began with basically 7 partners, which allowed us to move quickly. We basically contacted those systems. We received an agreement to coordinate between them and provide an integrated system with a single toll-free number, and I'll share a little bit about what that looked like. They all agreed to operate under a standard protocol for evaluation, and then the nurse triage line would prescribe oseltamivir via a protocol when it was indicated, and then they would call that prescription into a local pharmacy. And simultaneously, there was a parallel process where we were working with pharmacies to contract with them to take the state emergency response oseltamivir that was received from the stockpile and place it within pharmacies throughout the state. So we would take the medicine that was held by Minnesota Department of Health and distribute it to the pharmacies so that it was there and ready for people who came in who did not have health insurance, or if there were instances when the pharmacy did not have an adequate supply to meet demand. We identified a vendor to operate the front part of our nurse triage system, and we gave it a name of the Minnesota Flu Line. And this was a very short development timeline. We had our first discussions in early to mid-September, first conference call within a week. We began contract work with our nurse triage line provider, protocol development, and then pharmacy contract work starting at the beginning of October. As you can see, some of these activities continued even after we began operations on the 21st of October. It was a bit of a rough ride in the first few days. The demand was overwhelming. It exceeded, we added orders of magnitude to what we expected, and we still underestimated enormously because, as you'll see, we began right at the peak of activity in October in Minnesota. So what this looked like was callers called a 1-800 number, a toll-free number. They were screened by a medical screener at our contract nurse triage line, and quickly tried to identify people who were only interested in information, who were not ill, not exposed. 211 was a critical partner in providing that information, and we had a number of other resources that existed, including online resources that people were referred to. If they were ill or they were exposed to someone who was ill, we did some amount of screening for prophylaxis. They were referred to either a health plan that operated a nurse triage line. So someone said, oh, I have Blue Cross Blue Shield. Okay, we're going to transfer you to the Blue Cross Blue Shield's nurse triage line. Or if they did not have insurance or did not have a health affiliation, they were kept and screened and administered the protocol by our contractor. And so there was a number of outputs that came from administering this protocol. It was home care only, home care plus an antiviral, to call their physician or their healthcare provider, to actually go and see their healthcare provider, to go to the emergency department and to call 911. And remember, there was this parallel system of antiviral distribution where we pre-placed the medications within pharmacies, and I'll show you a map of where we placed them. We largely began with the largest chain pharmacies that could reach the most number of people and worked down from there, and sought a contract that would have a single distribution payment from the state that would reimburse pharmacies for the distribution of that medicine. But how it functioned when someone called the triage line and an antiviral was indicated, that nurse would ask for their pharmacy preference. They would then call that pharmacy and call in that prescription based on the prescribing authority of either the medical director or the state epidemiologist within Minnesota, who also co-signed this protocol. If there was adequate market supply, that pharmacy would just reach for that medication and bill insurance. If there was inadequate supply or someone was underinsured or uninsured, then they would utilize the state supply that was pre-placed. Yeah.
What was your experience with the health plans in terms of whose name went on the prescription?
So we do not know exactly how frequently it was the medical director's name of the nurse triage line within that facility, or how often it was the state medical director, state epidemiologist's name who was assigned. Both would have been allowed by state law, and I'll share a little bit about that. In Minnesota, this kind of thing was, which is another reason why we chose this model, is that they had been prescribing via nurse triage for periods of time. Some of them were very experienced and some were not experienced at all. So this was not a new thing for pharmacies to be receiving these phone calls from a nurse on a nurse triage line. So as Lisa mentioned, of those who had the protocol administered, and again, we siphoned off a whole lot of people before this point who were just interested in information. 62% of the people did not receive a recommendation for seeking in-person care, but I think it's just important to acknowledge that 38% of them did have that recommendation. And so it's not that we were just triaging people to the street primarily. We, in many instances, were telling them to go directly and engage with the healthcare facility. We have a number of stories of people when we did a survey after the fact. One very notable experience was someone who was convinced he had flu, but the nurse triage specialist who was taking the call was concerned about MI and told him to hang up and call 911, and it turns out that he was in fact having myocardial infarction, and that early intervention was critical in him doing well. There's additional added benefit, it was previously discussed, but the majority of folks were not recommended to seek in-home care. So,
Yeah, I noticed that the entry point into the algorithm was with a medical person or clinical person who screened, which seems, initially upside down to me, because I'm thinking that you're using non-clinical people as a sparing mechanism for the clinical people, like we said. But was that a conscious decision, and what was the rationale for that?
So a medical screener is a term that the facility used to, just as you said, it's an individual who has, in the grand scheme of things, the least amount of training. They were not nurses, were trained in the basic amounts of collecting information and screening individuals for those calls. But medical screening does not suggest that they had more advanced training at all. They were actually the least trained. That's just the term that the facility used.
Aaron, did you guys do an analysis of the recommendations that you made? So those that you said, go to a pharmacy to pick up the prescription or go here. What was the percentage of follow-up in terms of when you go and look what they actually did? Do you have statistics on that?
So I didn't share a lot of that. On the flash drive, there's a publication that we looked at some of this. Now, if we had designed this for the purpose of evaluating it, we would have made a lot of different decisions. We were trying to do this as fast as possible to get it done quickly. And so we did not have the ability to go back and track per person what was their outcome based on their recommendation. What we did was a survey, a callback survey of a proportion of the people who called in and asked them about their satisfaction, their outcome, and whether they found the service to be helpful. But we could not connect it back to what was the recommendation that was given.
Also, you only dispensed about 464 doses because we had a real narrow protocol then for antivirus. So,
yeah.
So what was the main difference in criteria that would lead the triage line to tell someone to have home care with antiviral intervention versus going to a primary care doctor or?
So this was based on CDC's treatment recommendations at the time. So it was really focused on identifying influenza-like illness symptoms, coupling that with their underlying health conditions. So screening them about their current health, and the symptoms that they had. So really this was following as closely as possible the guidelines at the time for the use of antivirals, both for treatment and for prophylaxis.
So for treatment, if they met those CDC criteria, then would they be told to stay home and get the prescription?
Right, so the second part of that is what is the appropriate level of care where this should be delivered. And so, for instance, somebody who has chronic kidney disease and is on hemodialysis, and the dosing of that medication will need to be different. In that example, their recommendation was the protocol said they get one dose and then they need to interact with their healthcare provider because the dosing would be typically every 48 hours. So there was caveats along the way, depending on the problems. And that's where interacting with medical directors of all of these nurse triage lines was critical, because that's what they do every day. They have these protocols designed to find the right place where people should be seeking care.
and you were conservative. I mean, you did not handle home care for young infants. You sent them for direct care. So there was a, conservative protocol.
Aaron, very quickly, did you say this was implemented or activated just prior to the second wave of H1N1?
Yeah, in the next slide, I'll show you where it fell within our...
Just a comment. I mean, would you envision a similar type of system stratifying clinically by severity, at least 5 categories, really being effective before a susceptibility profile or further situational awareness was available relative to the effectiveness of antivirals, the effectiveness of vaccine, and the severity of the pandemic to certain members of the population. So in other words, really, this would be a little different if we rolled it out immediately as a model for the first wave of a pandemic. Again, back to my comment about the severity of pandemics, the model created equal, this idea of collecting intelligence, public health intelligence, and antiviral susceptibility, vaccine efficacy, clinical symptoms and the most susceptible in the population play a big role in standing up any type of triage.
Absolutely. I mean, I think, you know, as has been mentioned, I mean, this is one tool in a much more complicated system of response. And I'll show you how it serves some of our populations that we were concerned that were not getting access in the same way. But completely agree with your comment. Yeah, I mean, we benefited from months of knowing susceptibility that, you know, entirely susceptible to oseltamivir, virtually susceptible.
So my point would be, as we move through this discussion, situational awareness by public health getting to pharmacists and other partners in the community during these types of dispensing models needs to be figured out as well. How do you get that situational awareness very rapidly with accuracy that helps define, you know, what's happening on the ground and how effective?
You know, I really think that's a really important give and take that needs to happen. If public health is going to be arranging CPAs and pharmacists, what pharmacists are going to need from public health is that situational awareness. Absolutely.
So what we did was we first looked at the largest pharmacies, the large chain pharmacies in Minnesota. It's Target, it's Walgreens, it's CVS, and sought to make contracts with them. And then we looked at the map and said, where are we missing? And then sought out smaller, even individual community pharmacies. And you know, this was a moving target. We were trying to get as many as possible, as quickly as possible. We had some areas of kind of the lowest population density up here in the northeast part of Minnesota, as well as the northwest part of Minnesota, where our coverage would not have been as great as we would like. Drive times were still probably 30 to 45 minutes plus to get to the closest pharmacy. We had a lot of a pre-placement within the metropolitan Twin Cities, Minneapolis, St. Paul area. And so in the red bars is our surveillance for laboratory confirmed H1N1 hospitalizations within Minnesota. This is October of 2009. And as you can see, we started the system during the week of highest activity within Minnesota. You know, of course, you can look at it both ways, one with regrets. We missed half of the amount of disease activity that occurred during that peak. On the positive side, we started it exactly when the need was greatest. Within the first 3 days, we had over 9,000 phone calls. And the call numbers in the line here dropped off in parallel to the disease activity as measured by the hospitalizations. So where did the calls come from? They actually, per population, so per 10,000 population, the greatest number of calls came from our lowest density population areas within the northeast Minnesota. So we really felt that we were meeting a need for individuals who may have had a difficulty accessing in-person care because of distance. So overall, we had 27,000 phone calls. We estimate that to be about 0.5% of Minnesotans. And importantly, over 17,000 of them needed information only. Some of our highest call volumes per capita were in the rural areas, as I mentioned, and up to 11,000 in-person healthcare encounters we estimate were prevented because of this service. In that callback survey that I mentioned, 92% of them said that they were satisfied or very satisfied with their experience. So just briefly about the legal framework, we feel that this activity was acceptable under existing Minnesota Minnesota laws at that time, in the absence of a declaration of the pandemic and of an emergency, and that is not the case in many states. So in Minnesota, a licensed practitioner may prescribe without reference to a specific patient via a protocol administered by a nurse, medical student, physician's assistant, or pharmacist. And we felt that it was supported by the existing Minnesota Mass Dispensing Authority. And importantly, as I said, all of the partner triage lines had a medical director, and many of them already, well, all of them already used protocols, and many of them used those protocols to actually prescribe medications. there were a number of things that we used that we feel added to the buy-in from the non-governmental partners that we had. First, I think it was critical that we engaged the medical directors to create a consensus document for the protocol. It added time. I think we probably could have stood up the system earlier if we had not had a more prolonged time for feedback, but I think it was critical to get them all on board. We cited the Federal Public Health Emergency Declaration and the PrEP Act because we just felt that that would help them in agreeing to this. And as I mentioned, the state epidemiologist and medical director signed the protocol under the delegated authority of the Commissioner of Health, who is also a physician. Yeah.
Aaron, what kind of response or feedback did you get from the medical societies? And second question is, did this information get communicated back when you knew of the primary care physician? Did it get communicated back to that physician? What occurred?
So we received overwhelming support from the medical societies. There were a few questions from the Minnesota Nursing Union related to, how were you, hiring these nurses? Was it equitable? That was not a major concern. It was just basically questions. And I'm forgetting the second part of your question, I'm sorry.
The documentation back to the patient's medical record.
So when an individual had a relationship with the healthcare delivery system, that call was transferred back to their nurse triage line. So they engaged with their own medical record system. For those calls that were kept by our contract service, there really was no way for us to be able to get that information back to another healthcare system because they already identified themselves as not having a close affiliation. So we did the best we could. That was important for the plans. They wanted to make sure that those communications could occur. That was something that they prioritized.
So Aaron, did you engage local city or county local health agencies prior to setting up the triage? And what was their reaction and involvement?
So as you recall, there's this kind of phasing in of all of these parts to it. They were very involved in the planning aspect of it. Just because it needed to happen so quickly, we tried to look for the smallest numbers of partners to engage with. And so in Minnesota, that was the plans. They operated at a state level, and so the state took the primary lead in that regard. But the locals were very important partners. Before we were able to get the medicine out to the pharmacies, many of them were actually driving state stockpiled oseltamivir to patients, which was a very unusual thing. It didn't happen a lot, but when there was a gap, there were many that just stepped up and said, "We'll take care of it." So it was wonderful to have their involvement. So there, of course, were a lot of lessons learned. I think most importantly, the telephonic triage system could have a major impact in decompressing the healthcare system as just one component during an emergency. And it really leveraged the existing infrastructure that was present in Minnesota with health plans and healthcare delivery organizations wanting to keep their own patients. That was very important. Overall, regarding cost to the Department of Health was $300,000 for administering the service to 27,000 individuals. That's just cost to the Department of Health, and we used public health emergency response funding that we received through CDC to pay for that. Now, again, the facilities, the partner triage lines, were spending money already administering their service. And we did not attempt to try to receive cost information from them. But ultimately, what this gave them was a pop-off valve for the enormous amount of people calling them. So I think everybody felt it was a win-win in the end. I think some of the other aspects that led to delay was we quibbled too much about the distribution fee with the pharmacies. And I think if we had just come to an agreement about what was a reasonable fee, it probably would have moved up that process faster. And it really came down to burden of documentation. That was a major lesson learned if we were to do this again, to adjust the burden of required documentation. So.
And is that, I'm sorry, is that documentation from the plans required or from?
So we were taking our medicine, putting it there. We wanted to make sure that it was not just disappearing off the shelves. So both to track and to try, we were attempting to try to get some information about the type of people who were receiving it. And so we had, you know, it was probably about 10 questions that we were seeking the pharmacy that was distributing the medicine to complete. For them, it was double data entry. It was extra work. And so we wanted to compensate for that effort for them in the same way that there was compensation for facilities who were administering vaccines as an administration fee.
For example, one of the problems was that was different than us in regular retail pharmacies. They wanted to report it back to them, the lot number that was dispensed. And we don't do that in regular community pharmacies, so it's how do we create this new system for this new reporting, which had to be done, because how do you write the story if we got what, where, when, if we don't report back to? But my question was, in Michigan as in Minnesota, it looks like what we had on our shelves was we had private inventory and we had our SNS stock. And the term uninsured became very uncomfortable. If one person came in and their private insurance covered it with a $25 copay, maybe that's good, maybe that's fine, maybe that's me deciding that's affordable for you. But if you're picking up 5 prescriptions because you're picking up for your family, well now, me on that line is kind of left with what is or what isn't. Did you give any direction to that pharmacy when they signed the agreement to dispense antivirals as to what uninsured may or may not mean?
We did not tightly define that. We really left that up to them to really encourage them to liberally interpret that. If somebody came, that was part of our marketing of this is a service for people who don't have insurance too. And so this provides you access to medicine where you don't need to pay for it. What we were trying to guard against was having lots of disease activity and just be literally sitting on a mountain of oseltamivir that wasn't getting used. So we really wanted it to go out, and we never tried to assess how well various pharmacies were screening, but kind of in our communications with them really encouraged them to be liberal in their interpretation.
And that's what we did at Maryland as well, just to let you know.
It was complex because no one anticipated the commercial supply still being so viable at the same time we were having this incident. So I tell you what, I have totally derailed Andy and Sarah's timeline, but the conversation I think has been really excellent. And thank you, Dr. Stewart, as well, and you, Chris, for your really important remarks in this morning's session.